لا مايكرو بيولوجي.
CD4 Eliza. Karam, please write your ID on the exam paper. You just write your name and khalas. Okay? This time result is better, huh?
Alhamdulillah.
But still I need more from
Inshallah.
boys.
Inshallah.
Girls improved a lot. This time 3 girls scored full marks, 6 out of 6. And boys, inshallah, you need still more. Some of you did well as compared to last, but still, but Karam didn't write ID. I don't know what is his problem. Okay. We were discussing the penicillins.
Yes.
Discuss the natural penicillins. We know that they are one of the most important group of antibiotics for the reason that they act on the structure that we don't have in our cell, and that is the cell wall. And for this reason, they are considered to be quite safe because we don't have this structure in our body. But that doesn't mean that there are no side effects. Still there are side effects, and we will look into these side effects. The side effects of the penicillins, that in general, the most important one, what we say, direct Coombs positive, and that can lead to analytic. This is a test that is performed that maybe you have discussed with Dr. Abdurrahman, the types of hypersensitivity. There are 4 types of hypersensitivity, type 1, type 2, type 3, and type 4. 4 types of hypersensitivities. With penicillins, because penicillins are also antigens, they are foreign bodies when they go to our blood or plasma. So sometimes proteins, these antigens which enter into our body, the body start to produce antibodies. So producing antibodies in response to these antigens, that is called Coombs test. So if the body is producing these antibodies, so we say this is Coombs positive test. And although it is not very common that all the patients suffer from this, but it can happen, and that can lead to hemolytic anemia. And you know hemolytic anemia means that there will be hemolysis of the
red blood cells.
RBCs, or red blood cells. The most important side effect with the penicillins, that is type 1, or that is called IgE mediated. As you know, we have 5 types of the white blood cells, and we have 5 types of the immunoglobulins. So IgE means immunoglobulins E, or that sometimes for our reference we say immunoglobulin eosinophils, because eosinophils are also producing the same problems. Allergy, very good. So what will happen, that there is possibility for urticaria and anaphylaxis. Now definitely you have discussed it in immunology that type 1 hypersensitivity is of 2 types. Again, in type 1, there are 2 types. One is called immediate, and the other one is called delayed. Immediate means that you give the drug to the patient, and sometimes within minutes the patient will develop allergy, And sometimes maybe after 1 day, 2 day, 3 days, 1 week, the patient will come back and tell you, doctor, I have allergy. So that is delayed.
2 weeks.
Yeah. So anaphylaxis is important because anaphylaxis could be fatal. And for this reason, if you remember in the general pharmacology, I told you that whenever you give penicillins, what is required? TD. What is TD? Toxic dose?
In the skin, sir.
That is test dose in the skin, test dose. Whenever you give or prescribe penicillins, especially injectables, injections, then you must ask your Filipino nurse, because mostly in private Filipino nurses are more, that please give test dose. Because I told you that I can still remember a young lady, she died because of anaphylactic shock of the penicillin. So although it doesn't happen, but who knows who will suffer from this problem. So be careful while prescribing penicillins. They are very effective, they are very good. We are prescribing them for many bacterial infections, but keep in mind that they can cause type 1 hypersensitivity reactions, what we say immediate, that is a matter of seconds, not minutes or hours. Within seconds the patient will go. So that is the worst situation. But mostly what happens, there will be skin rash, widespread, and inshallah when you will travel to America, especially maybe in Canada and these countries also, you will find people, they are wearing bracelet. Like you see when you go to Haram, the people who come from outside, they wear bracelet, Ujjaj and Mutamari. Similarly, in these countries, you will find sometimes people wear bracelet. Is in the hospitals you will see. And these bracelets for penicillin allergy. So if the patient cannot recall or the system, he is not on the system, so whenever the doctor sees, oh, this is a penicillin sensitive patient. So it is so important. It can also cause type 2 IgG mediated, as we discussed, that is hemolytic anemia. And sometimes it can cause serum sickness like syndrome, that is type 3. In short, for us the important one is type 1 hypersensitivity that can be caused by penicillins. Okay, now we come to the another important penicillins that we prescribe or we use in our clinics. In the last lecture, we discussed that bacteria, they change their plans or strategies because they know that antibiotics, they are our enemies. So what they do, that they produce enzymes which are called penicillinase or beta-lactamase. And these enzymes, they inactivate the antibiotics. So if the enzymes inactivate the antibiotics, so these will be called penicillinase sensitive antibiotics. Penicillinase sensitive antibiotics. And the two important ones that we use for this purpose, first one is amoxicillin per oral, and the second one is ampicillin per oral as well as IV. Underline amoxicillin. Amoxicillin is the safest antibiotic. It is the safest antibiotic. So if you get question on your exam, which of the following is the safest? Amongst all antibiotics, it is the safest antibiotic. But the problem with amoxicillin is that amoxicillin is penicillinase sensitive. What do we mean by penicillinase sensitive? If bacteria is producing enzyme penicillinase, then amoxicillin will not be effective. Why? Because it will be destroyed or catalyzed by the enzyme penicillinase which the bacteria produce. So that is important. Mechanism of action is same, all of them, they have same mechanism of action. They will act on the cross linkages, peptidases, penicillin binding proteins. It will block that and it will rupture the cell wall synthesis. Spectrum, as we discussed, spectrum means that whether it is effective against gram-positive or gram-negative. Same as penicillin, as well as it is effective against some other bacteria. So, amoxicillin is broad spectrum. It is broad spectrum. The natural penicillins, if you look here, the penicillinase, the original penicillin, they are narrow spectrum because they are effective against certain bacteria. Here you see amoxicillin is effective, amoxicillin as well as ampicillin, there is no big difference in the two. They are also effective against many other bacteria. And you see, they are effective against, first one is H. influenzae. What is H. influenzae? Haemophilus influenzae. It is gram-positive or negative?
Haemophilus influenzae?
Yes.
I think it's negative.
Negative, very good. It is gram-negative. Then H. pylori, you might have discussed with Dr. Abdurrahman also in microbiology in for peptic ulcer disease, one of the greatest reason. H. pylori, Helicobacter pylori.
I think Dr. Abdurrahman said that the lecture of H. pylori was deleted this year.
Deleted, okay. Yeah, the lecture is deleted. What we will do? It is gram-negative.
Also,
Next is E. coli. E. coli. E. coli is gram-positive or negative? Positive. Yeah. And negative. E. coli is the most important bacteria. Why? Because it is present in our body as normal flora. In intestines it is present as normal flora, and at the same time it causes various infections in GI as well as in urinary tract. In females, as inshallah you will go by, and when you will get married you will know, urinary tract infections are very common. They are very common.
Very common.
And the most important causative organism, for urinary tract infection in females is E. coli. Up to 70%, 70%, urinary tract infections in females, they are caused by
E. coli.
E. coli. So you can understand how commonly it causes urinary tract infections. It can also cause even meningitis, CNS infections, but the commonest is urinary tract. Then Listeria, then Proteus, then Salmonella, then Shigella, and then Enterococci.
They are all mix of positive and negative.
Most of them, they are negative. If you recall your first lectures in microbiology, for us, gram-negative bacteria, they are challenged as compared to positive. Why? The bacterial cell wall of the gram-negative, it is more resistant to the antibiotics. So you will see, even when you will practice in your clinics, that gram-negative infections need more antibiotics as compared to gram-positive. While bacterial cell wall of the gram-positive, it is easier. It is thick-walled, 3-layered, but still it is easier to be penetrated by antibiotics. Rest you will not find quite common at except these two, Salmonella and Shigella. Salmonella causes the GI infections. Similarly, Shigella, it also causes shigellosis or dysentery, diarrhea. So these are important, and all these they are gram-negative. Use of amoxicillin. Where do we use amoxicillin? First one is strep pharyngitis. Strep pharyngitis. Strep pharyngitis means when the pharyngitis is caused by streptococcal bacteria. Although it is not very common, but if you recall your school days, it is common during that period. From 5 years to 14 years. When you are in school and you suffer from throat infection, in that age it is quite common. After that, mostly it is violent. But even whenever there is bacterial infection, streptococcal, and good thing that these streptococcal bacteria, they don't produce penicillinase that cause the strep pharyngitis. So that is good thing. The next where we use amoxicillin, that is in H. pylori. So one is gram positive and the other one is gram negative. And then ampicillin. Hope you will not use, inshallah, ampicillin except you are maxillofacial surgeon. So those who are planning to be maxillofacial surgeons, you will use, because mostly we use them in injections, injectables. Ampicillins, they are used as injectables. So like you see, listeria, meningitis, elderly and neonates. So you know neonates, we cannot give oral, we cannot give tablets, capsule. So the best option in neonates are injectables. Similarly in elderly, they don't cooperate, sometimes they can't take, can't swallow, so again injectables. Group B strep meningitis, again in neonates, and similarly group B strep, PX stands for patient's pregnancy. So pregnancy is a special situation that is only in females. So you can say that it is safe even in pregnancy, whether it is amoxicillin, whether it is ampicillin. So if you get question on your exam, that you have a patient in your clinic and you need to prescribe an antibiotic, which one is the safest? So amoxicillin or ampicillin, both are safe. So if both are there, option A, B, C, one is amoxicillin and the other one is ampicillin, then amoxicillin. Okay? Amoxicillin is on the top. If for some reasons we cannot use amoxicillin, then we will go for ampicillin. Okay. Then next group, the side effect is allergic reaction, like all penicillin derivatives, because they are synthetic penicillins, they will cause allergic reaction, type 1 hypersensitivity reactions. But another thing that it can cause sometimes, and that is worrisome, that is C. diff colitis.
What is C. diff?
Yes, the last time even I wrote here C. dat. Dat is Baba, huh?
C. dat?
Yes. Clostridium difficile. Clostridium difficile, it is anaerobic bacteria and it can cause diarrhea. Clostridium difficile associated diarrhea. C for Clostridium, this D for difficile, this A for associated, this D is for diarrhea. The other name for this is Clostridium difficile colitis. Clostridium difficile colitis. It can cause Clostridium difficile colitis and sometimes it is problematic. We will see, even if you remember we discussed it, if the patient is alcoholic, if the patient is suffering from some problems, so how we will use the metronidazole and vancomycin. In the first slide, vancomycin and metronidazole.
So doctor, the use of amoxicillin and ampicillin will appear as MCQ in the exam. Mention the use of ampicillin, for example.
Yes.
And you will say we will use it for Listeria meningitis, for example.
Yes.
Like this?
Yeah. What we will do, because normally if you look at the exam, we try to focus on common things like you have nothing to do with Listeria meningitis. You are not neonatologist, you are not pulmonologist. In dentistry, for example, if you have a patient and you are oral medicine specialist, so you might have patients who are suffering from strep meningitis. So normally we focus on common things. These are like Listeria meningitis, group B streptomeningitis, group B patients, they are not common for you. But why we put it here, sometimes just to confuse, like I asked the question and I put it in options. So for this reason, we need to add. In general, we ask common things which are more related, like you will have a patient and he will be telling you that I am using amoxicillin for the last 2 weeks. So apparently there is no infection. The patient is in your clinic, he is not suffering from cough, sneezing, chest, anything. Then you should think why he is using this amoxicillin, because he is not suffering from any infection. When you take the history, were you suffering from fever, throat infection, something, he says nothing. So how you will think, why is using this amoxicillin? So this is one of the infection where there is no fever. Normally in fever we have, in infection we have fever. But there are some infections where there is no fever. And one of the example is H. pylori. So like if we ask question that patient is in your clinic, is using amoxicillin, although there is apparently no infection. So which infection where there is apparently no fever or things like that? So that is to give the give you the idea. Okay. Next is penicillinase resistant. These are the antibiotics that resist the enzyme penicillinase. They are not easily destroyed by enzyme penicillinase, so they are called penicillinase resistant. Dicloxacillin, nafcillin, and oxacillin. Mechanism of action is same, but spectrum is narrow. They are used against certain bacteria. They are not used against many bacteria. MSSA, I don't know whether you discussed it because you are performing also practicals. MSSA
stands for what?
Yeah, but I'm asking. Something is related with Saudi Arabia? Because SA is there.
Yes.
For you, being a dental students and doctors normally, later on also, some bacteria are very important, like Dr. Abdurrahman might have told you, like streptococcal bacteria, because they cause many oral problems, and aerobic. Second one is like E. coli. If you study microbiology and you don't know about E. coli, it means you never studied microbiology, because E. coli is called pet bacteria. You understand pet bacteria?
Yes.
It is everywhere in the lab. We can easily grow, we can perform practicals on it. So it is like pet animal, like here maybe cats, some people also like dogs, like you maybe, huh? You don't? Okay. Okay, so that is our pet bacteria. Then there is another bacteria that is very important. Why it is very important? Because we classify even antibiotics on that. And I know you discussed it, that is called SA. SA stands for Staph
Aureus.
aureus. Staph
Aureus.
aureus. It is so important. Why? Because many Staph aureus, they produce penicillinase enzyme. And we face problem. Even today, one of the biggest challenge to microbiologist is Staph
aureus.
aureus. Why? Because many Staph aureus, they produce beta
Lactamase.
lactamase, and beta lactamase inactivate many antibiotics. So we say methicillin susceptible or sensitive Staph aureus. Methicillin sensitive
Stuff.
Staph aureus. What is methicillin? Methicillin is an antibiotic. It is an antibiotic. We don't use normally in clinics because it is highly nephrotoxic. Highly nephrotoxic. We don't use. Where do we use? We use it in labs, microbiology lab. You perform practical for culture sensitivity? Any idea about culture sensitivity? Growth of bacteria? Growth of bacteria
On the culture,
in the culture? How we can grow bacteria?
by incubation in the incubator for 48 to 24 hours.
24 to 48 or 48 to 24?
48 hours. Let's say
24.
20.
24. Mostly 24. Even less than 24.
Yes.
Okay, I will show you just zone of inhibition so that you could be able to understand zone of inhibition. Zone of inhibition. Okay, I think it is good. Okay, now you see at this picture what these small things, white, this white, this white, this white, this white, this white.
CD?
Microorganism.
Antibiotic disc,
Disc.
like CD that previously used in computers. This is disc.
Yes.
Antibiotic
Disc.
disc. So, what is this circular thing? What is this called?
Agar.
Yeah, this is agar. The container that carries agar. The container, like bottle.
Ah.
So what is that called? Where we put agar, because where you will put agar?
Plate.
Plate. What is that plate called?
Culture.
Yeah. Culture is the product. Petri dish. It is called Petri
Petri
dish. The scientist who discovered was Petri. So it is called Petri dish. Dish is a plate. So it is a Petri dish. As you said, there is media. It may be McConkey, maybe agar, maybe chocolate, maybe blood, whatever. And then we grow, as you said, for 24 to 48 hours. When we come back next day, we see there is growth of the bacteria. Then we insert the discs. Now you see here there is this gray spot, there is gray spot, there is no spot. Here there is no spot. So if this is called zone of inhibition. Zone of
Inhibition.
inhibition. What does that mean? That the bacteria is effective. The bacteria is effective. It is killing the microbe. So you see which one is the largest in this circle, this one and this one. So for example, we say that this antibiotic is methicillin. This is methicillin. So what we will say, methicillin sensitive Staph aureus. MSSA. Methicillin sensitive Staph aureus. At the same time, you see there is no gray area. Look here, there is no gray area. Here, no gray area. So what we will say that, what is this? For example, we say that the bacteria is Staph aureus. and the antibiotic is not effective. So what we will say? Methicillin resistant staph aureus. Methicillin resistant staph aureus. MRSA. One is MSSA and the other one is MRSA, that, and SAMSA is also here, Tosila. So MRSA, methicillin resistant staph aureus. MSSA is methicillin sensitive staph aureus. So that is how we classify the antibiotics based on it. What happened? Okay, go back to this. Yes. So, where do we use? In methicillin sensitive staph aureus as well as in group A streptococcal, that are the strep pyogenes. What is pyogenes? Pyogenes, those bacteria that produce
Pus.
pus. Very good. Pyogenes is from pus. So those bacteria that produce pus, that is the group where we use. Where the use is, first one, methicillin sensitive staph aureus infections. Methicillin staph aureus sensitive infections. Why they are important for you? Because you are dealing with infections in your clinic. And there is possibility like you are doing surgery, extraction of tooth. After tooth there is infection. So if it is methicillin sensitive infection, we will use dicloxacillin, nafcillin and so on, or oxacillin. The another very important use, and that is quite specific, that is with mastitis. Mastitis. If you remember, we discussed in GIT, in prokinetic as well as in acid peptic disease, gynecomastia,
Enlargement
of breast in
Enlargement of breast.
in males, because in females it is normal, but in males there is no enlargement of breast. The point that I am trying to make, gyne is female, mastia means breast. Here what we say, mastitis, inflammation of the breasts in males or females?
Females.
Females, very good. This is in females. Why? During pregnancy, in the last month of pregnancy or after delivery of the child, sometimes there is infection in the breast. That is called mastitis. And what is the best choice? That is dicloxacillin. Why dicloxacillin? Because dicloxacillin is safe both for the mother and child. Dicloxacillin is safe both for the mother and child. This is, for example, if you get question on your exam that you have a patient, she delivered a baby, she is suffering or diagnosed with mastitis. So which one is the best option? Amoxicillin is there, ampicillin is there. So the best answer is dicloxacillin, because dicloxacillin is effective and it is safe both for child and mother. The problem that we face with dicloxacillin, nafcillin and oxacillin, underline nafcillin. Nafcillin, underline.
Where is this?
In the beginning, penicillin is resistant, dicloxacillin, nafcillin and oxacillin. Underline nafcillin. Nafcillin is withdrawn from the market. Why? Because it is highly nephrotoxic. It is highly nephrotoxic. And one of the side effects of penicillin is resistant, that they can cause interstitial nephritis.
Especially nafcillin.
Yes. Like yesterday you see the case, today you discuss case,
Yes.
new case.
Yes.
That is related with renal failure. there is also nephritis. So that is one of the problem that we face. Okay, now we go to next, that are the beta-lactamase inhibitors and anti-pseudomonal. Beta-lactamase inhibitors, as I showed you last time picture, the one that you will use quite commonly in your practice, that is clavulanic acid. Clavulanic acid, sulbactam and tazobactam. But remember, if you get question on your exam, which of the following beta-lactam doesn't have antibacterial activity? Clavulanic acid. Clavulanic acid alone, no antibacterial activity.
It's about
Yeah, it only supports the penicillin to enter to the cell wall. That's it. Otherwise, if you give alone and think that it will treat or kill the bacteria, no way, because itself it is having no antibacterial activity. Mechanism: protect penicillin antibiotic from destruction by inhibiting the enzyme penicillinase or beta-lactamase. What I showed last time, that it is just like a cover, and that cover helps that the bacteria cannot recognize that who is inside the cover. So penicillin goes and it attacks the enzyme that is required, the enzyme which is in the bacterial cell wall. Okay, so amoxicillin, clavulanic acid, piperacillin, tazobactam, ampicillin, sulbactam, ticarcillin, clavulanic acid. Cross all the three except the first one, because those who will be inshallah doing maxillofacial, they will use rest of the three. All the last three, they are injectables. Piperacillin, ampicillin and ticarcillin, all the three, they are injections. The first one, that is injection as well as oral. Mostly you will use it in your clinics as oral. For almost all dental infections, the best option is amoxicillin clavulanic acid. That is the use of beta-lactamase. Another group, that is anti-pseudomonal penicillin. Anti-pseudomonal penicillins are those which are effective against Pseudomonas aeruginosa. This is one of the bacterial infection that takes place in hospitals. Nosocomial infection.
Nosocomial infection.
Yeah, and they are very difficult to eradicate. It is gram-negative and it is very difficult to eradicate. So, piperacillin and ticarcillin, look here, piperacillin with tazobactam, ticarcillin with clavulanic acid. So they are injectables and they are used. Spectrum is broad, gram-positive, but no MRSA. So what is MRSA? Methicillin resistant staph areas. They are not used in methicillin resistant staph areas. Gram-negative Pseudomonas and nosocomial infections are organisms combined with beta-lactamase. Ticarcillin and piperacillin always in combination. They are always in combination with clavulanic acid, tazobactam and sulbactam. Alone they are not used. Where we use for Pseudomonas infections. What I told, that we use it for Pseudomonas infection. Now, the most important thing that you will face in your clinics, the side effect. Augmentin is the trade name of amoxicillin and clavulanic acid. Very effective, very good choice. It covers all the anaerobic bacteria in our dental clinics. But the problem that we face, sometimes when the patient takes amoxicillin and clavulanic acid for 3 days, 5 days, the patient calls you back, doctor, I am suffering from severe diarrhea. Severe. So what is that severe diarrhea? that is Clostridium difficile colitis. Clostridium difficile colitis. Now this Clostridium difficile colitis is again anaerobic. It is anaerobic. And you need to treat it. The first choice is to treat it with metronidazole. If you remember, you go back to the first
Yes,
slide.
it's used for anaerobic bacteria.
Anaerobic bacteria.
Yes.
So anaerobic bacteria, Clostridium difficile is anaerobic bacteria, and metronidazole is good choice. But what is important, my computer teacher, that the patient says in the medical history that is alcoholic.
Uh-huh.
So what you will do now?
Replace it.
Because if the patient is alcoholic, we cannot use metronidazole. So what you will do now? Go back. Huh? Clindamycin is also terrible. Huh? Clindamycin will be used to treat infection. Now, infection is being treated successfully by amoxicillin and clavulanic acid. He says, I have no fever, nothing related to infection. My problem is now that I am going every 30 minutes, 1 hour to washroom because there is severe diarrhea. And when you go back to the medical history, is alcoholic.
Clindamycin.
Clindamycin is used to treat infection. You are right, is alcoholic, so you can use clindamycin instead of metronidazole. But now here the situation is different. We didn't prescribe clindamycin. We prescribed amoxicillin, clavulanic acid. Okay? Or you prescribed clindamycin, no problem. Still he is suffering from diarrhea. Now how you will treat this diarrhea? And the best option is metronidazole. The best option is metronidazole to treat this anaerobic diarrheal infection. But the problem is that is alcoholic.
But مو قلنا الميترونيدازول انه افضل شيء معاه بالانيروبيك.
Yes, but if the patient is alcoholic, so now what you will do? It should be written. We discussed. Yes.
Diptomycin.
Daptomycin. Vancomycin.
Why?
If you remember, I told vancomycin is used only injectables, except there is only one use for vancomycin capsule, that is to treat
Gram positive.
gram-positive, that is injectables, injection. But we use vancomycin capsule. We use vancomycin capsule to treat CDAD.
Capsule for CDAD.
For CDAD. Otherwise, gram-positive only in hospitals to treat the systemic infections. But if you find a patient who is using vancomycin capsule, so what should come to your mind is suffering from CDAD. Okay? So that is the point that is important for us. I think we finished. Okay. Now, cephalosporins. Cephalosporins are the younger brothers of penicillins. The mechanism of action is same. The only thing that is good in cephalosporins that they are resistant to beta-lactamase. They are, no, but all penicillins are not resistant. Here they are resistant to penicillinase, more resistant as compared to penicillins. One thing. Second important thing, that they are marra ghali, very expensive as compared to penicillins. Yes, they are marra ghali as compared to penicillin. So not good choice in common practice. Why? Because you will get patients every day and they're very much expensive, maybe 10 times
Oh,
more expensive than penicillin. So if we should use them carefully, look into the pocket or the bank balance of the patient. Yes, general principles. There are 5 generations of cephalosporins. First generation, second generation, third generation,
fourth and fifth.
fourth and fifth generation. 5 generations are there. How do we classify them based on generation? Please look and listen to the questions. Why? Because sometimes this comes in the exam. How do we classify cephalosporins based on generation?
Effectiveness, maybe.
Based on spectrum. Based on
Spectrum.
spectrum.
dictated السؤال
Gram positive, gram positive, gram negative, gram positive, gram negative, gram negative. Didn't get the point. Let us try to understand. Generations from 1 to 4. 1 greater than 4 equals increased gram negative spectrum of activity. Got it? Yes or no?
Yes.
No. Very good. What happens? First generation is more effective against gram positive. What I told in penicillins, for us the challenge in the clinics is always gram positive or negative?
Negative.
Gram negative. So first generation gram positive. Second generation gram positive, gram negative. Third generation gram positive less, gram negative more. Fourth generation gram negative more. Fifth generation gram negative more. Even anti-sodomone, we will see. One of the group is also covering anti-pseudomonal in this.
Doctor,
Yes,
can you repeat it please again?
I am repeating.
First generation,
Yes,
gram
yes.
positive.
Yes. First generation gram positive.
Second,
Second generation,
Both.
gram positive, gram negative. More gram positive, less gram negative. Third generation, gram positive, gram negative. But more gram negative, more gram negative. Fourth generation, more gram negative, more than third generation. Fifth generation, more gram negative, more than fourth generation. Every time we are going up in generation, more gram negative.
In first generation, there is a lot of gram positive,
A lot of gram negative, less of gram positive.
but there is gram positive.
Yeah, the gram positive are there, like first generation, gram positive. But when we go to second generation, now gram positive and gram negative. Third generation, gram positive but more gram negative. Fourth generation, gram positive but more gram negative. Fifth generation, gram positive but more gram negative. So, going up, more gram negative. The important thing for the fifth generation, that it is not only broad spectrum but it is also used for MRSA. So, if you get question on your exam, which of the following cephalosporin generation is used to treat MRSA infections?
generation 5, fifth generation.
Fifth generation. Okay? Like your super Z generation or which generation?
Gene Z.
Z? Only Z? Or super Z? 1, 2, 3, they will be absent because according to Dr. Fatih, anyone who comes after 9 o'clock will be absent. He is Mudir Kabir. Okay. So, mechanism of action is same, but what I told, less susceptible to break down by penicillinase. Less susceptible. They can fight more against the enzyme penicillinase. They can fight more against the enzyme penicillinase. Now, specific drugs. First generation, cefazolin IV and cefalexin per oral. Second generation, cefotaxime IV, third generation ceftriaxone, IV, IM, ceftazidime, fourth generation cefepime, fifth generation ceftaroline. You don't know, need to remember all except third generation. Except third generation, underline third generation. Third generation ceftriaxone, IV and IM, and ceftazidime. These are the two that inshallah you will prescribe those who will be maxillofacial surgeons and endodontists. Those who will be endodontists and maxillofacial surgeons where the infections are more severe, more resistant. Those who are specialized in root canal. Yeah. What is in Arabic? I don't know. Huh? Jadur, yeah. So these are the two. The most difficult thing in dentistry is endodontist. Mostly it is failed. And when it is failed, doctor is failed. Doctor maafi manzoor. So that is the most important thing. And where we use these injections. Normally, you don't need to prescribe injections. So if you are a maxillofacial surgeon, you will prescribe ceftriaxone, intramuscular, intravenous, or ceftazidime, intravenous. Rest, inshallah, you will never use in general dental practice. They are used in specialized conditions. That is the story of the cephalosporins. So now we take our next, just give 5 minutes break and then start the next. Yes, one more lecture.